Hello, and welcome to Noon Conference hosted by MRI Online. Noon Conference was created when the pandemic hit as a way to connect the global radiology community through free live educational conferences that are accessible for all. It has become an amazing weekly opportunity to learn alongside radiologists from all around the world, and we encourage you to ask questions and share ideas to help the community learn and grow. You can access the recording of today's conference and previous Noon conferences by creating a free MRI Online account. The link will be provided in the chat box. You can also sign up for a free trial of MRI Online Premium membership to get access to hundreds of case-based micro-learning courses across all key radiology subspecialties. Learn more at mrionline.com. Today, we're honored to welcome Dr. Brandon Brown for a lecture on pediatric imaging. Dr. Brown is a vice chair of radiology and associate professor at Indiana University. His interests include fetal imaging, medical ethics, and medical education. He is chair of professionalism for the RSNA and works for a pediatric radiologist at Riley Hospital for Children. At the end of the lecture, join Dr. Brown for a Q&A session where he will address any questions you may have on today's topic. Please remember to use the Q&A feature to submit your question so we can get to as many as we can before our time is up. With that being said, we are ready to begin today's lecture. Dr. Brown, will you please take it from here?
Great, thanks so much, Olivia, and welcome to everyone who's joining us for the Noon Conference. I'm happy to be here. This is a return visit for me to the MRI Online Noon Conference series, and today we're going to be talking about genitourinary anomalies in the pediatric population. So I'm going to go ahead and share my screen, and hopefully you all will be able to see my first slide up there, pediatric genitourinary disease.
We can, you're good to go.
Okay, great. It's a big topic and we've only got an hour, so I'm going to move as quickly as I can. I'm going to start out with the urinary tract and then hopefully we'll have time to get to the genital tract as well. So our objectives for this session are to look at some real life cases and talk about things that are frequently encountered. We'll also discuss some rarities, but focus on the common. And we're going to dip into embryology. I know embryology is not always everyone's favorite topic, but it really helps a lot to understand what's happening in the embryo and the fetus in order to understand the genitourinary anomalies that are frequently first identified in the newborn period and even prenatally. So antenatal hydronephrosis is the #1 indication for ultrasounds after birth. And so we will follow up on some of those embryology questions. And then I want to emphasize over and over during this lecture that urine is moving down a one-way street. So almost all of our problems can be identified when we see disruption of that one-way traffic of urine. So moving along, we're going to look at cases of antenatal hydronephrosis, and we're going to look at some of those embryologic anomalies and even some associated cases that start out as ventral wall defects or failures of the ventral fold to close. So this is a fetal MR image of a bladder outlet obstruction, a lower urinary tract obstruction, and you can see this really expanded bladder and posterior urethra. This turned out to be a case of posterior urethral valves, but we're going to be looking at cases like that, upper and lower areas of obstruction. So just why is it important to be able to identify these things early? Well, it turns out that prenatal hydronephrosis is something that's very common. It's a very common cause of all prenatal abnormalities. It's also a very common cause of, the ultrasound imaging that we do after birth. We can also see it with fetal MRI as well as prenatal ultrasound. And there are cases now where we're doing intrauterine intervention. So if there's a bladder outlet obstruction, for example, you can place a shunt which will decompress some of that fluid. And there's been variable success with that intervention. There are also amnio infusions. So if the fetus doesn't void, then the amniotic fluid gets swallowed and now there's no more amniotic fluid. It's not coming back out. And sometimes we can infuse supplemental amniotic fluid to help the fetus. So what we're going to be doing in most of these cases prenatally is we're going to be looking at the diameter of the renal pelvis. And these are some of the numbers that people frequently cite as cutoffs. And as you can see, the number changes around the 33-week period. Interestingly, the 33-week period is also a really important time in terms of whether the lungs are undergoing net absorption of fluid or net secretion of fluid. So we can see a lot of corollary effects in the pulmonary, the fetal pulmonary system with the urinary abnormalities. And that ends up being a really important determinant of outcomes. So this is a two side-by-side images of prenatal ultrasound. If you're disoriented, you don't commonly look at these images, always look for the shadowing from the fetal spine, and you can see the shadowing here, so you know where posterior is. And then on either side of that spine in the retroperitoneum, of course, are the fetal kidneys. And you can see measurements taken of the renal pelvis here. This is a fairly common thing to see a little bit of fluid in the renal pelvis. Sometimes our obstetrical colleagues will refer to this as pyelectasis. Postnatally, we would say pelviectasis. That's not a concerning finding. Here we can see a little more asymmetric dilatation. This is kind of a traditional transverse, or we might say axial view, where you can see that fluid in the renal pelvis. And then this is more of a coronal view. You can identify the splitting, the bifurcation of the great vessel. So that's too much fluid. That's abnormal and asymmetric renal pelvic dilatation. And that's something that's going to be followed up after birth. Here's the corollary of the fetal MRI. This is the maternal body is upright, but the fetus is in cephalic presentation. So that's why it's upside down. And you can see bilateral renal pelvic dilatation, but much more severe on one side than the other. It can be sometimes difficult to determine what side you're on, but here's the stomach. So we can be pretty confident it's the left kidney. We've got calyceal and pelvic dilatation there. And then here's what it looks like on an axial image of the fetal body on MRI. So here's the spine, of course. Here's a renal pelvic dilatation here, some renal pelvic dilatation here, and then this massively dilated ureter as well. So we know there's some distal obstruction. So what happens with all these cases of antenatal hydronephrosis? Well, many of them don't mean anything at all. So we try not to get too worked up. We do follow up cases that we identify as abnormal, but a lot of them end up being normal, and it's a smaller subset that we have to end up doing things for postnatally. The fluid in the renal pelvis is going to move, larger and smaller during gestation. And anytime we see bilateral concern for obstruction, that's going to have worse outcomes. Obviously, complete bilateral obstruction can be fatal if the lack of voiding and the anhydramnios leads to pulmonary hypoplasia in the fetus. So we do look at those renal pelvic diameters, and we do know that there is some correlation that if you see it dilated earlier to a greater degree, then those are the patients who are more likely to need intervention. There's a lot of reasons for that dilatation. In addition to the vast majority, which are just physiologic, we have obstructions in the upper urinary tract and the lower urinary tract. We can have lesions of the ureter themselves, including ureteral atresia. We can have duplicated systems where there's a ureterocele at the bladder blocking one of the duplicated ureters. We can have valves, both posterior and anteriorly in the urethra. You can have strictures, although those are certainly more common in the postnatal population, especially post-traumatic. Children often undergo, so-called saddle injuries. So, if it's non-obstructive, there can still be dilatation, and that can be due to repeated pathologic reflux. That can be due to a congenital megaureter, or some of the syndromes that we see, prune belly syndrome, sometimes called Eagle-Barrett, and then cloacal exstrophy, which is a severe failure of the ventral wall to close, and bladder exstrophy, which is a slightly more mild abnormality on that spectrum. Bladder exstrophy is frequently non-symptomatic, and there are not any ureteral or renal imaging findings because it tends to not obstruct the flow of urine. Cloacal exstrophy is slightly more complicated and can have problems because there's an associated omphalocele. So why are we doing all this diagnosis? Well, it's, to treat. And what is our goal with treatment? You might think it's to fix the kidneys or to preserve the kidneys, but that's actually our secondary goal. Our primary goal is the lungs, because, if you're born without kidneys, or if you're born with pretty weak and incompetent kidneys, we can fix that. We can put you on dialysis. We can find transplant kidneys for you. I mean, I don't want to suggest that it's simple, but it's possible. But if you're born without lungs or without functional or sufficient lungs, there's not much we can do for you. There's no such thing as neonatal bilateral lung transplants. That's not part of modern medicine, at least not right now. So we need to make sure your lungs develop properly, because pulmonary hypoplasia and severe pulmonary arterial hypertension is devastating and can be fatal for many cases of congenital urinary tract anomaly. And as I mentioned earlier, failure of the kidneys to function, or failure of the kidneys to be able to pass urine because of a blockage, leads to low or absent amniotic fluid, which means no swallowing, none of that fluid going in and nourishing the lungs and helping them grow. And so our problem is really lungs. We are going to follow up these cases first prenatally and then right after birth. And then sometimes we'll do fetal MRI if we suspect there's a syndrome, if we suspect that there's a little bit of a lack of clarity of whether it's urinary tract dilation or GI tract dilation. A big loop of bowel and a big ureter can look similar. And then I mentioned there are rare interventions. There has been some discussion in the urologist community about using antibiotics prophylactically at birth, and that's controversial, but certainly we're going to follow up with more imaging. And, when do we do that? One of the things is the fluid levels in fetuses, the overall fluid status can be quite variable, and there's a risk of both dehydration and fluid overload. So we try not to image right after birth, and that's always a struggle. As radiologists, I think that you'll find that if you indicate something on prenatal ultrasound, then there's going to be a temptation or a desire for the clinician to get that follow-up postnatal ultrasound on day 0 of life, day 1 of life, boom. And we really try and encourage our colleagues to wait just a little bit until we can get to a more normal fluid status. And then we can accurately assess whether there's hydronephrosis. We don't want, false positives and false negatives. So we will image in cases of severe obstruction right away. But if it's, mild or mild to moderate antenatal hydronephrosis, no harm in waiting a week or two. And then, what ends up happening with these kids? Well, there's variable outcomes, of course. There's a big study from urology in 2011 that looked at nearly 1,500 kids who had antenatal hydronephrosis identified. And in this sample population, more than half were normal. And then you can see the breakdown of what the outcomes were. So very commonly vesicoureteral reflux, which also can be normal. And then some obstructions at the UPJ and UVJ, and then a very small percentage of other problems like valves, ectopic structures, and ureteroceles, syndromes being the rarest. So the vast majority of cases, 70%, are either normal or we identify some vesicoureteral reflux. And as I'm going to talk about later, it may be that we're not helping much by finding some transient, asymptomatic vesicoureteral reflux in a newborn. So there's a lot of systems to grade hydronephrosis. The original system was described by the Society for Fetal Urology. It's a system that's still used in many places around North America, at least. I can't speak as confidently about Europe or elsewhere in the world, but it's the original system, and it's still preferred by many urologists. Now, there are newer systems. There's one that looks at the anterior posterior diameter, the APD, and really emphasizes that, integrates it sometimes in combination with this SFU, Society for Fetal Urology system. And then there's also the newest system, the urinary tract dilation, the UTD system. And that has been accepted and implemented at a number of places, but it certainly has not completely replaced this traditional system. And just in my own part of the world, here in the Midwest United States, we're still using this SFU system quite a bit, and it really is variable based on what your urologists want you to use. So I'm not going to spend a lot of time talking about the pros and cons of those because we have a lot to get to today, but just be aware there are other systems, even if you have learned this traditional original grades 1, 2, 3, 4 SFU system. So here are the grades. Technically, grade 0 is a thing, but I don't know many people who will diagnose grade 0 because we call that normal. So please just say normal. And then here's some examples. This is a normal kidney in a newborn. Might look a little bright to you if you're used to scanning adults, but this is normal for a neonate. Or premature infants can have even brighter echogenicity on the renal ultrasound at birth. Here's grade 1, just a slight splitting and opening up of that renal pelvis, but we certainly didn't see any calyces. And now we're seeing just a little bit of the major calyces. And that's going to continue, as you might expect, from the major calyces to the minor calyces in grade 3. And then finally, the most severe grade 4 in this SFU system has cortical thinning, scarring. There's permanent damage that's happened to the kidney. So this is, of course, the most concerning. And in some ways, we're a little too late here. That I don't mean to suggest there's no hope, but permanent damage has already occurred in grade 4. So how are we going to work up these cases? Well, obviously, normal cases don't need any workup. Some people would say grade 1 antenatal, hydronephrosis, we're not always grading it, doesn't need to be worked up. And you saw those numbers. So many of those cases are normal, but we typically follow up the antenatal. And if we see it at birth, most people will follow that up at least one more time. In the past, it might have triggered a referral for VCUG because, we see that a lot of these cases of hydronephrosis are caused by vesicoureteral reflux. Now, do we need to find every case just because it's happening? Well, probably not, because there's such a thing as, benign reflux, transient, limited benign reflux, and the management of those cases has changed. And so increasingly imaging centers, including my own, are changing our imaging to kind of reflect the management. If urology is not going to treat benign transient reflux, we're not going to do a VCUG to find it. So, grade 1 hydronephrosis, we don't do VCUGs unless there's some other indication. Grade 2 or kind of persistent reflux, we will do a VCUG. And certainly with grades 3 and grade 4, we're going to look not just for reflux and structural abnormalities, but we're going to look for function. And that's what the nuclear medicine studies can do for us. We use MAG3 pretty frequently here. So when we do a VCUG, we're looking for, reflux, which can be benign. We're looking for structural anomalies like a ureterocele. We're looking for abnormalities of the urethra in males. Hard to see much in females in the urethra. And then we're going to do some functional physiologic imaging to try to specify what the kidneys are still able to do. The anatomic appearance and the physiologic function often go together, but sometimes they don't. For example, we will see abnormal kidneys that seem to have a lot of residual normal parenchyma in the prenatal imaging. After birth, we'll do a functional study and find, there's kidney there, but it's not actually working. So we can't assume that anatomy equals physiology. And then we're going to look at, bladder outlet obstructions, of course. And we're going to try to see if we can identify sometimes the cause of downstream abnormalities. So severe, persistent, and refractory hypertension in the newborn population is much more likely to indicate an abnormality in the kidneys or in the renal vessels. In the older pediatric population, it's not really as much of a good predictor because there's so much obesity in that population, and that's a much more likely cause of hypertension. The prophylactic antibiotic therapy that I mentioned earlier, that's no longer a consensus view among urologists. And in fact, even if there's a urinary tract infection, a first-time urinary tract infection in a young child, does not automatically trigger antibiotics, does not automatically trigger the VCUG in some of our urology viewpoints. So there's some controversy about how quick our trigger finger should be on some of these things, because it's not a simple matter. Getting a catheterization for a voiding cystourethrogram is not a pleasant experience for many children. And unfortunately, if they're children who have already been previously traumatized, it can be quite upsetting. And parents obviously don't want to see their child suffer or even be distressed. And so we try not to take the VCUG study too lightly. It is an invasive procedure, and we don't want to do it unnecessarily. So a lot of these patients will improve over time, those grade 1s and some grade 2s. The grades 3s and 4 are going to get intervention. So what about this vesicoureteral reflux? What is the way to deal with it? Well, first we need to know if it needs to be dealt with. Is it benign? Is it incidental? Is it asymptomatic? A lot of these cases will be outgrown or, only transient. But for the persistent or severe types of vesicoureteral reflux, there is going to need to be some kind of treatment. And as you can see in these images here, the angle of insertion of the ureter into that detrusor muscle, into that bladder wall is really important. The steeper the angle, the more muscle there is surrounding the distal ureter, the more it can prevent reflux. The more of a 90-degree angle with the ureter coming almost at a transverse to the wall of the bladder, there's not as much muscle. And so one treatment would be to do a reinsertion and try and achieve, for example, an angle something more like this that you see here, rather than this right angle. Another option that's been used by various urology groups is to inject some sort of inert substance, and we call it deflux, the one that's used where I practice, and it can narrow that outlet of the ureter at the bladder wall. Here you can see some being injected, and it can also help with reflux. That's used variably, and the indications for one or the other, or the practice of using one and not the other, is highly variable depending on location. So you'll want to get to know your urologist and find out what their practice is. But both treatments have been used to prevent pathologic or symptomatic vesicoureteral reflux. Obviously, if there's a ureterocele, that's going to need to be treated and removed or taken down. Here you can see a filling defect in the bladder, a large ureterocele, typically at the location of ureteral insertion. Here you can see even after the bladder has been progressively filled, there's a large area of filling defect. In this case, this ureterocele is low and central, so we would be concerned about a ceco ureterocele, which is just a ureterocele that falls into the bladder outlet and can cause bladder outlet obstruction. So it's more symptomatic, it's more concerning, and needs to be treated with more urgency. Here's an ultrasound, postnatal ultrasound example of a ureterocele. You can see this thin membrane surrounding a large amount of fluid centrally within the bladder, and that causes obstruction, typically at the ureteral insertion to the bladder, but as I say, it can also block the bladder outlet. When we see ureteroceles, that automatically points us to a duplicated system. It's not necessarily associated, but it's frequently associated with duplicated system. So we're going to, of course, want to look at the kidney, and we're going to want to look not just for duplication, but for obstruction because of the ureterocele. So here you can see variable amounts of fluid filling the upper and lower moieties of this kidney. And you can see this tortuous dilated ureter associated with that left kidney, or associated with one part of that left kidney. This was a completely duplicated system, and it's the upper pole that traditionally has been identified as obstructing. The lower pole can reflux, but the upper pole will be the one that leads down to that ureterocele and obstructs. And over time, if left untreated, it's the upper moiety of the kidney that, because of chronic obstruction, will develop cystic dysplasia and will often scar down. So if you're seeing an older child for the first time, they may only have a tiny bit of echogenic tissue residual scar up at that upper location where the upper moiety used to be. Here's an early image. You can see that there's asymmetric dilatation between the upper and lower moieties, but there's still some renal tissue around that. So we're not yet at that point of cystic dysplasia. And here's the corollary VCUG image, where you can see reflux coming up this ureter and going into what's been sometimes described as a drooping lily. This is the drooping lily sign. And in other words, we're only filling the lower moiety. There's presumably a collecting system that matches that would have been for the upper part of the kidney, but it's not lighting up here because it's communicating via an entirely separate ureter. We also see on this patient a large ureterocele. And so presumably the ureterocele is associated with the ureter going to the upper moiety, but we can't see that because there's no contrast refluxing. Either there is no reflux, or that ureterocele is preventing reflux. So when we see duplicated collecting systems, we look for all of these things. We look for obstruction, we look for ureteroceles, we look for that upper moiety to maybe show signs of scarring or damage. And then we want to identify the insertion of those two ureters down on the bladder. And the thing to remember is the Weigert-Meyer rule. This tends to come up on board exams and other, quizzes, which ureter is going to insert where, and it's that upper ureter that's ectopic, that's abnormally inserting. It's the upper ureter that's obstructed. It's the upper ureter associated with the ureterocele. And being ectopic, not orthotopic, not where it should be, but ectopic, it's traditionally going to be lower, more inferior, and medial to the normal ureter. So you've got your normal ureter mirror image of the other side, which is presumably a single collecting system. And then medial and inferior to that, you've got your secondary ectopic ureter. So these are all things to bear in mind when you're doing your renal ultrasound and VCUG imaging. Here's an artist's illustration of the two ureters. The one that's dilated and tortuous is connected to the ureterocele, and you can see here it's lower and medial to this orthotopic normal ureter, and that's the upper pole. Here's a nice VCUG image showing both systems at once. So in this case, there was not an obstructing ureterocele, and occasionally we will see reflex into both systems. So you can imagine an entire renal parenchyma around both of these systems. And if you only looked at the bottom one by itself, you might call it a drooping lily. But now we can see the upper moiety and the lower moiety. And then for comparison purposes, this left side is singleton. Here's a lily on radiography compared to a VCUG. So you can see where the name comes from. And here is an ultrasound, or I'm sorry, a VCUG image of the bladder. And you can see just ever so faintly down here, two different dense lines coming up from the bladder. So we're getting a very subtle indication of a duplex collecting system. And then up here, you can see there's this lower moiety and then a second ureter going up to the upper moiety. So sometimes the findings can be very dramatic, sometimes less so. And here's a further image of this patient with duplicated collecting systems. Here's a sagittal image trying to identify the point of insertion of the ureter. And this is an illustration when the insertion is not only ectopic, but it's not on the bladder at all. In fact, the ureter can frequently insert on the bladder neck or the urethra, which you might have a patient present with continuously being wet, even after they have, been trained to use, bladder control. Or it can insert on the vagina in females, also would present as continuously being wet. In males, uncommonly, but we do see it, it can insert on the seminal vesicle. And that introduces bacteria into the genital tract. So those patients can present with orchitis and epididymitis. Now, we frequently think of a teenager or a young adult with epididymo-orchitis as having a sexually transmitted disease, gonococcal infection, and that being the cause of their abnormality. But rarely, especially in young children who, we hope don't have sexually transmitted diseases, it can be because of an ectopic ureter that's allowing urine to get into the genital tract and potentially cause that infection that you might first identify on a testicular scrotal ultrasound. So we're going to skip ahead a little bit to some embryology. We're going to talk about urinary tract dilatation because of obstruction. And this is just a reminder that we have different structures coming together. We've got the mesonephric duct, and then we've got the renal blastema. And those two different structures have to merge with the ureteric bud. And in order to have a fully functional system, there has to be not just fusion of the structures, but there has to be a cannulation so that the kidney, the final kidney, can allow the urine to flow freely into the ureter, into the bladder. So if there is never a complete fusion of those structures, or if they fuse but don't open, you're going to have some type of UPJ obstruction, ranging from complete obstruction to narrowing, stricturing, and all along that spectrum. So UPJ obstructions can cause variable levels of abnormality and hydronephrosis, and they will present at different ages. So the more severe the obstruction, the earlier they present. But we will see young adults, teenagers, first-time presentation with hydronephrosis, and it turns out they have a mild UPJ obstruction. And, if you lose some of those signaling factors, you get failure of complete fusion of the structures. This is a physiologic study, a nuclear medicine test showing a failure of the contrast agent to be able to pass out of the kidney. And you can see the asymmetry and how much uptake there is first, and then how much excretion. So a severe asymmetry between right and left sides. And then even when we get down to the excretion, the later phases, even after the administration of Lasix, you can see there's a significant delay. So nuclear medicine studies can help us to identify how severe the obstruction is, how responsive the kidney is to Lasix, how much delay there is, or if it's a complete obstruction and there's zero excretion. And of course, we can measure, half-lives and time to excretion. So this is what's so valuable about being able to combine the anatomic and the physiologic imaging. So just to show how these things can develop over time, the kidney might start out normal, looking like a newborn, admittedly echogenic, but normal newborn kidney, all the way to this very severe obstruction as it has become progressively more severe, and there's been progressive renal damage, scarring, cortical thinning over time. So this is a case where if we act with urgency and if we are accurate in our initial diagnosis, we can prevent a lot of harm. This is not always true, but there is a subset of patients, especially those grade 3 patients and some of the milder grade 4 patients, where we can intervene early and prevent a lot of damage. The milder cases, maybe there's less concern, and the very severe cases at birth, maybe all the damage has already been done. Here's a cross-sectional study, obviously postnatal, looking at asymmetric dilatation. You can see quite dramatic difference in the thickness of the renal cortex between right and left. And then you can see it's not just renal pelvic and calyceal dilatation, but also the proximal ureter is quite dilated as well. That's a patient with a UPJ obstruction. Here's another example, a little bit more distal. You can see some of the pelvis has become extra renal because of the pressure dynamic of this obstruction, with pelvic calyceal dilatation severe. This is obviously grade 4. And then here's an example where contrast has been injected. This is not going to be an image you would be able to obtain on a VCUG in a severely obstructed case, because the contrast can't make it back to the kidney, but you can see this massive renal pelvis completely featureless. There's definitely calyceal dilatation there as well, but you can't identify discrete calyces, the fornix of the calyx, or any of that. It's all expanded and I would say almost blown out, because of the severe increased pressure and obstruction. Here's a less dramatic example. Again, this contrast is being injected into the kidney percutaneously and showing that focal narrowing at the point of the atresia. And in cases of UPJ obstruction, there are various causes. We don't fully understand how every case develops. We know that it can be the embryologic process has been disrupted. It can be abnormalities because of genetic deletions and mutations of the smooth muscle. It can be neurologic abnormalities. There can be extrinsic structures. So these wouldn't be embryologic problems with the kidney, but maybe you have, duplicated IVC or an abnormal position of the ureters that are quite medial, and there's pressure from a vessel or some other structure. So when it's a case like that, those cases can often be treated without urologic intervention. But in many cases of true UPJ obstruction, a pyeloplasty is required. That atretic segment has to be removed, and then a new anastomosis created. In a UVJ obstruction, of course, the blockage is down by the bladder at the ureteral insertion of the bladder. Similar problems, it can be intrinsic to the muscle or the nerve. It can be due to the insertion angle of the ureter, or it can be extrinsic from aberrant anatomy. And of course, we all know of the phenomenon of calculi. That's typically seen in a much higher rate in adults than it is in children, but older children do tend to get renal calculi, and children with, abnormalities of calcium and phosphate. So there's various causes. Here's an example of the progressive changes. So in 2006, this patient had both pelvic and calyceal dilatation. And then you can see it's almost hard to find the kidney. In 2007 and 2009, there's progressive atrophy and scarring. And what little tissue does remain is very echogenic. This is not echogenicity because of the newborn, this is scarring. And if we did a MAG3 study or some other physiologic function test, there would not be a function there. So what's the outcome? The outcome of this is cystic dysplasia. And I want to separate that from an MCDK. MCDK is an abnormality of development where a renal pelvis never forms from the earliest parts of embryology. Renal cystic dysplasia is in response often, not exclusively, but often in response to chronic obstruction. So like a UVJ or a UPJ obstruction. And these are going to progressively involute. They don't require surgical intervention if we've already identified a lack of function. Now, the surgical intervention can preserve function. It can intervene before we've reached that point of total scarring. But once you're there, no surgery is required. In the past, that might have been excised, that little residual scarred tissue. Now we just leave it. It doesn't cause problems. There is no concern for transformation into any other kind of malignancy. That's not always true with multicystic dysplastic kidney. And remember, that's an error in embryology where the kidney never even forms properly. That can have malignant potential. And so the treatment is different. But if it's obstruction leading to cystic dysplasia, we just leave it alone. So I'm just going to briefly go through a couple of other cases so that we have some time to look at the genital tract anomalies. Here's a 17-day-old who had prenatally diagnosed hydronephrosis. You can see pelvis and calyces are dilated asymmetrically on the right side. And when we did a retrograde, injection of contrast, you can see that the distal nature of the obstruction leads to not just renal pelvic and calyceal, but also ureteral dilatation. And this was a primary obstructing megaureter. Here's a newborn. You can already right away on this renal ultrasound see there's some thin membrane in the bladder. Maybe you're thinking about a ureterocele. I hope you're thinking about a ureterocele. And not only do we have renal pelvic and calyceal dilatation, but a very tortuous ureter down by the bladder. So we're thinking about a distal ureteral obstruction, not a UPJ. Here's some more images of both the kidney and that tortuous dilated ureter. And then on VCUG, you can see a filling defect in the bladder, and you can see this ureter. You can see almost this bear paw configuration of dilated pelvis and dilated calyces. And you can see the severe obstruction on this MAG3 study where even, at 40 minutes, there's not really much passage of contrast. So this patient ended up having a ureterocele, and that chronic obstruction had led to cystic dysplasia. In fact, there was so much pressure in the collecting system that there was a urinoma in the left upper quadrant. So it didn't reveal itself quite as nicely on this nuclear medicine study, but there was a collection of urine from a rupture of a calyx. So this was a very severe blockage and also a vesicoureteral reflux. Here is a pregnant patient with fetal urinary tract obstruction. Here's the fetal spine, and you can see bilateral abnormalities. One looks like a very enlarged pelvis. This looks like multiple cystic structures. So those could be calyces. With this single image, we also would have to consider, could those be cysts? This is, later in the process, cystic dysplasia. But now that we're down here at the pelvis, we see this massive bladder. We're starting to think, well, this isn't a ureteral problem. This is a bladder outlet obstruction. And of course, on this sagittal view, you can see dilated kidney, dilated pelvis and calyces and ureter and bladder. So confirming our suspicion, there's another view of both the kidney and the bladder, and another view here as well. And so what we ended up diagnosing in this case was that there was a bladder outlet obstruction. The right side had already involuted. and just caused cystic dysplasia. So there wasn't really urine being produced. That's why the dilatation looked asymmetric. So just in summary, I want to remind you that for our grading, those milder cases can be followed up a little bit later after birth to wait for that fluid to rebalance, to normalize. For severe cases, we need to act quickly and be aware of the way that urologists are treating at your institution, because there is some variability in how they want those kidneys to be graded and what type of interventions they're offering, for example, for vesicoureteral reflux. I'm going to skip ahead. In the second portion of our hour, I'm going to talk a little bit about genitourinary disease at the genital tract aspect, and consider just a few of the diagnoses you ought to be aware of. So this is sort of the part two. And here is a image on a fetal MRI of a 24-year-old who has this bilateral urinary tract abnormality in their fetus. And you can see spine here, renal pelvic dilatation on both sides, and some dilatation here. Now, this is the bladder, but note what's going on here. This is the insertion of the umbilical cord. So we're seeing pressure in the urinary tract that's actually recanalizing the structure that connects the bladder to the cord. In fact, that's the way that the early embryo and fetus voids. And I'm talking, of course, of the urachus. Now, at this point in gestation, you can see how large the fetus is. There shouldn't be voiding through the urachus, but increased pressure can cause that to remain open, and it can be sort of like a decompressing effect for the bladder. Here's the bilateral ureters as they're coming off the kidneys, obviously very dilated. Here's a picture of just how much pelvic calyceal expansion there is on this fetal MRI image. And here it is again. You can see the bladder here, a little bit of urine moving towards the bladder neck, but also a significant amount moving through the urachus and out into the base of the umbilical cord. So that can be an indicator to us of just how high pressure of a system it is. And here you can see a companion case. These were both the same diagnosis. We've got massive expansion of the collecting systems, massive expansion of the bladder. This is a bladder outlet obstruction. This was posterior urethral valves. And here's the classic image that's been used traditionally to describe a keyhole appearance, because we're seeing a dilated bladder and also a dilated posterior urethra. So sometimes you'll see that listed, keyhole bladder. In posterior urethral valves, just like with UPJ obstruction, the valves can be completely obstructing, which is going to cause more severe changes earlier, or they can be incompletely obstructing. And rarely you can see pediatric patients present quite late in life with posterior urethral valves, in their teenage years, that have been just obstructive enough to cause damage, but not quite obstructive enough to make the damage so severe that they were having symptoms. So it's a kind of a gradually progressive thing. They may show up at age 12, 13 years old. You scan their kidneys, they've never been scanned before, and they've got all this renal scarring. And it's because of this chronic partial obstruction. Here's an example of severe hydronephrosis in an older patient who presented with posterior urethral valves. Here's a voiding cystourethrogram, which shows a very abnormal bladder. Note how elongated this bladder is. Note the irregularity of the bladder wall, and that sort of undulation or trabeculation is the sign of chronic obstruction. So in many patients with congenital anomalies of the spine, they can end up with neurogenic bladder. And that will also be elongated, dilated, trabeculated, because the bladder is basically contracting against a closed door. And so the bladder muscle becomes very abnormal. In some cases, it becomes too strong, but it's strong in a disordered, disorganized way. Same thing here. The bladder is contracting over time against a closed door, and the muscle develops in unhelpful ways, and it changes the peristaltic activity of that bladder. The muscle starts forcing urine backwards or to the sides, and it ends up looking very abnormal, as we see here. In posterior valves, we know that there's an actual abnormality of the folds of the urethra. And we know, like I was saying, that the presentation can be quite variable. The cases we see early are the most severe typically. If we identify it antenatally, prenatally, we can sometimes try to intervene. There have been various treatments directly to the urethra. This is a small structure in the fetus, so you can imagine that would be quite challenging and not always successful. And sometimes we just try and deal with the secondary effects, as I mentioned at the beginning, shunting fluid out of the bladder into the amniotic space. And if necessary, if there's no amniotic fluid, we can infuse a supplemental amniotic fluid. There have even been cases where ports have been placed in the maternal abdominal wall with a catheter extending into the intrauterine space. And then the patient, the maternal patient, can undergo chronic, recurrent infusions of amniotic fluid over the course of however much of the pregnancy is left. These are very controversial treatments. They're not used everywhere, and they're not always successful. It requires a lot of patient compliance. It requires incredible regular visits to the hospital, and even then with variable success. So lots of follow-up, lots of monitoring in those cases. Here's just an image showing the areas of the posterior urethra that tend to be dilated proximal to this membranous urethra, and that gives us that keyhole appearance that we see. And often in valve cases, we can see them more distally. So this is a case, you'll notice an abnormal bladder, quite trabeculated, and then you'll see this outpouching, but that's not the posterior urethra, of course. That's much more distally. That's an anterior urethral valve. And interestingly, anterior urethral valves tend to be caused by a flap of membrane tissue in the urethra that leads to a diverticulum. It diverts the flow of urine. It creates an abnormal jet against the wall of the anterior urethra. And over time, that jet creates an outpouching, a diverticulum. So anterior urethral valves frequently seen with anterior urethral diverticula. And this is just such a case. Here you can see it gets quite expanded. You might even be tempted to think this is the tip of the urethra at the fossa navicularis, but it's not. The external meatus is way down here. This is the outpouching from the membrane causing abnormal dynamics of that fluid jet during voiding. And here's some cases of pathologic photographs and surgical images showing the membrane that was diverting the flow of urine and that has to be resected. And you can see significant enlargement of the external genitalia because there's significant enlargement of the urethra. So those are rare cases, but if you just remember that there can be valves anywhere along the urethra, most commonly posterior, but also possible anteriorly. It's a good thing to keep in your differential when you see those abnormal presentations. Another presentation that can look like a bladder outlet obstruction, very similar to urethral valves, is prune belly syndrome. It can give us that enlarged bladder, dilated tortuous ureters, big kidneys. But in this case, there is no valve. There's some abnormalities of the musculature, and it's not just the urinary tract musculature, but also the abdominal wall musculature. So here you can see this is a KUB radiograph, an umbilical stump clip right here. And you can see how the anterior abdominal wall is not competent. And all these gas-filled loops of bowel are sort of hanging out from what should be a tighter intraperitoneal space. There's just a lot of expansion of that space. The anterior abdominal wall is very flaccid. And so there's also, association with cryptorchidism. And this can be very hard to tell apart from posterior valves prenatally. Postnatally, it's not a difficult question at all because the appearance, the visual appearance of the abdominal wall on an infant with prune belly is quite distinctive. It's quite memorable. So no one would be confused with an image like this. So remember, just because something's in your differential as a radiologist, it might not be a differential decision or a dilemma for the pediatrician. So it's good to communicate with our colleagues, and we can know more together than each of us knows in isolation. Very rarely we can see urethral strictures. As I mentioned, these are uncommon in the prenatal or neonatal period, but they are possible, and there are very uncommon congenital urethral atresias. All of these, depending on how severe, would present with bilateral, usually symmetric, renal pelvic obstruction, ureteral obstruction, enlarged bladder. I'm going to move past this case of anterior urethral stricture and talk about the genital tract. I just want to briefly remind us all of the Mullerian ducts and the fact that there's a fusion of the two Mullerian ducts, and if any point along that process of fusion, there's an interruption, then there can be abnormal separation of the two sides of the uterus, the two sides of a septated vagina. And there can also be abnormalities at the point of connection between the posterior vagina and the anterior vagina, because the posterior or deeper portion of the vagina is associated with the uterus and develops separately, and then fuses with the more distal or anterior vagina, and that's going to be associated with the urogenital sinus. And so if there's a failure of complete fusion or opening up, just like we were talking about with UPJ obstructions, you can have abnormalities there. You can have a transverse vaginal septum, you can have an imperforate hymen, all of which can cause genital tract obstruction. So here's an artist's illustration of the fusion of the Mullerian ducts, the red on this illustration, and they should completely fuse at the uterus and at the vagina, and then the walls at their point of fusion should be resorbed completely to have the normal configuration. If that gets interrupted, we see abnormalities of fusion, and we can see various anomalies. The most sort of severe end of the spectrum would be a unicornuate uterus, where the rudimentary horn of the other side is completely disconnected or not even visualized, all the way up to the least severe, the arcuate uterus, where the only thing that hasn't resorbed is a tiny bit of residual myometrium at the fundus. And you might think, well, that's not a real problem. And you're right. If it were just a little bulge of muscle at the fundus, who really cares about that? It's not nearly as big of a problem as having, like a didelphys uterus, where you've got two different uteri, and, there's a potential for asymmetric pregnancy and things like that. The only thing to bear in mind is that with the muscular anomaly, with the residual muscular tissue, there can also be a thin membrane down the center. And the arcuate uterus is highly associated with a septated uterus. So we might not be seeing it on these 3D ultrasound images, 4D ultrasound images, but if there's a septum there, that can lead to abnormal implantation. So here's a patient, teenage patient having problems with menstruation. There's a workup with a pelvic ultrasound, and here's the corollary MRI. And you can see just the tiniest little bulge. Here's the myometrium on ultrasound right here, and then these echogenic endometrial spaces. And then here on MRI, it's much clearer that there's just a slight thickening. This is an arcuate uterus, not too much of a problem by itself unless associated with a septum. Here's another image where you can see septation. So this arcuate uterus has a very thin, almost imperceptible uterine septum, and then down here, as you get closer down by the cervix, it's much more obvious. That's a big problem because of implantation in the case of pregnancy. And I'll show you an example of that in just a minute. Here's patient number 2. This is a transverse ultrasound image, and you can see there are two different horns of the uterus. This one shows the endometrial space a little bit better than this one. And this was a bicornuate uterus. Now you can have the cervix be single, bicornuate unicollis, or you can have bicornuate bicollis. That's not the same thing as a didelphys. It just means that there's such a deep residual division, it extends all the way down to the cervix, but there is some degree of commonality. The very external os of the cervix would be singleton, even though the deeper cervix, the internal os, would, be duplicated. So this is the bicornuate. The way to tell the difference between this and the arcuate is you need to see the outside of the uterus. If there's this cleft on the external aspect, it's bicornuate. If we saw this appearance, but the fundus was normal, we would call this a very dramatic arcuate uterus. And here's another case where you can see a uterine fundus here on ultrasound, uterine fundus here on ultrasound, with the big extrinsic cleft between them. Another image, 17-year-old, two different fundi, and one of them is a little bit dilated. We're thinking, could that be a gestational sac? Could they have an asymmetric pregnancy? And in point of fact, that patient did have an asymmetric pregnancy. Here's another patient, separate patient, where you can see cross-sectional imaging demonstrating the didelphys, the twin uteri, which this is just a more severe degree of failure of fusion. Here's a septation, which can be associated with any of these Mullerian duct anomalies. and that septation has obstruction somewhere distally. You can see all the fluid filling the endometrial space. Here's a serial MR imaging of a patient with 2 fundi, but as you come more distally towards the cervix, one of those funduses disappears. And when you get down to the cervix, you only have the one structure. This is a unicornuate uterus, which this side extends down to the cervix, with a rudimentary horn that's completely obstructed. It has endometrial tissue. It is going to attempt to slough off that endometrial tissue with hormone shifts. So menstruation might be attempted, but if there's no outlet, you can develop increased pressure. Here's some blood fluid levels, and that needs to be resected eventually. There are even rare reports of these leading to a pregnancy in the rudimentary horn. There are several mechanisms proposed. Very rare, unlikely, but it has been reported. So here's all the Mullerian anomalies. And I just want to return to this question of a septated uterus. And it's why we care even about arcuate. We look very carefully for a septum because the septum doesn't have myometrial tissue. And myometrial tissue, the inner myometrium, is necessary to develop all of those spiral arteries, to create the proliferation that is the precursor to the placenta. So you need this decidual reaction to develop a placenta. If the zygote or blastocyst or whatever stage it's at implants into the endometrium on this septum, but there's nothing behind it, it's not going to be able to develop the vasculature necessary to sustain a pregnancy. So there are patients who present with recurrent miscarriage, and the cause can be a septated uterus, and they're just having multiple pregnancies implant on that septum. So if you see any form of Mullerian duct anomaly, look very carefully for a septum. The septum can be up high only, or it can extend all the way down into the vagina. And it's a little easier to detect in those cases. And lastly, in our final few minutes, I just want to talk for a moment about a urogenital sinus. The most severe form of failure of separation of all the different tracts at the pelvis and perineum is a cloaca. And I have an image here of a chicken because in the normal anatomy of the chicken, there is only a cloaca. The eggs emerge from the same vent where the fecal matter and the urine emerge. It all comes from the same place. And if you've ever owned chickens, you've collected some eggs that have a little bit of dirt on them, we'll say, but they're not completely clean. You have to wash those eggs. In the human, of course, there should not be a cloaca. That's an embryologic point that's only transient. And then we should first have separation of the GI tract from the urogenital tract, and then later separation of the urine from the genital tract. If that gets interrupted, you can have a cloaca. That's a more severe abnormality, or even more commonly, you can have a urogenital sinus where you have a normal sphincter for your anus and rectum, but only a single common channel at the perineum for urine and genital tract. And that's going to need to be repaired by urology. So urogenital sinus is an abnormality that we can identify. This is an adult patient who had a fluoroscopic study where contrast was injected into the cloaca, and you can see all 3 tracts. Typically in children, we'll do a VCUG if there's a suspected urogenital sinus. And sometimes it can be quite easy to catheterize through that common channel into the wrong tract. So here's a case that I performed where I thought I had catheterized the bladder. It can be quite difficult to identify. You inject a little bit of contrast, and you'll note right away that this structure on top of what I thought was the bladder leads us to quickly realize we're not in the right place. And in fact, we're in the genital portion of this common urogenital tract. And when I turned the patient sagittally, you can see a very clear outline of the cervix. So this is contrast that has gone into the vagina. You can see it in the fornices of the posterior vagina and a tiny little string going through the cervix up towards the uterus. So we pulled the catheter back and we redirected. And here now you can see we've gone anteriorly into the bladder. Because there's a common channel, when the patient voided, contrast refluxed even more back into the uterus and vagina. So you can see a quite dilated vagina here, and then an anteflexed uterus that overlaps with the bladder. So this is a case of urogenital sinus, and you'll notice that there is a short common channel, and that's a good thing for the patient. The short common channel gives much more latitude for the urologist to separate the urethra and reimplant that. If there's a long common channel, there's not much channel that's individual to each tract, and that's very hard to repair. So when you're doing these studies, you're often asked to evaluate the length of the common channel, short common channel equaling better prognosis. And here's all those images all together. So just reaffirming what I said, short common channel is best. I'm going to stop here because I think we've reached our 1 o'clock hour. I know I have some questions in the Q&A, and I will take any questions that you have from the audience at this point. So thank you all for your attention.
Okay, you just want to start at that top one and then just read down.
Great. So we have a question here. How useful is ureteric jet angle to screen for vesicoureteral reflux in children? And I'll say I've only seen a couple of studies on this. Of course, we love it when we see the ureteric jet. And often you can see it on ultrasound. You put your Doppler on and it looks like Doppler signal because of the fluid dynamics. However, and we can also see it on MRI because you can see fluid dynamics on T2 weighted MRI, like a single shot fast spin echo will show turbulence of black and white fluid in the bladder. But there's a lot of problems if you don't see it. You don't know if they're just not voiding at that moment or if it's truly obstructed. So it can be helpful for looking at urine going the right way when you see it. Now, looking for urine going the wrong way, which is what the question is getting at, I find very challenging to see. It's been much more successful with ultrasound contrast agents, and there's a lot of data and studies. Many of them in the United States, many of them have come from Children's Hospital of Philadelphia. There's a very active group there. There's a lot of this going on in Europe as well. Research showing the value of contrast agents with ultrasound following those micro bubbles up into the ureter. Question number 2, is there any dimension to measure for hydronephrosis grade 1 so you can diagnose earliest grade 1 different from grade 0? And I guess the question is there a size cutoff there? And I can't say that there's a consensus view on that. I think any splitting of the renal pelvis, any fluid at all, technically is grade 1. What's more controversial is, do we care? Does grade 1 hydronephrosis even matter? Some people would say, no, I'm not going to give antibiotics. I don't want you to do a VCUG. So any opening of that renal pelvis is grade 1. What you need to do is have a conversation with urologists. Do you guys care about, grade 1 hydronephrosis? Next question. The degree of obstruction when use of Lasix is contraindicated for diagnostic evaluation. So certainly there's cases of severe obstruction where you don't want to use Lasix. It can only increase the pressure on what we know is an abnormally closed or obstructed system. The question is, at what point would you say you shouldn't use Lasix? And I think that it's a little tricky because a lot of times you don't know how much obstruction there is when you're giving Lasix. So what we try to do is we try to have our ultrasounds scheduled right before our VCUGs or right after our VCUGs, and then the nuclear medicine study in the afternoon. And that way we can call our nuclear medicine physicians and say, we believe there's a severely obstructed urinary tract. Severe grade 3 or grade 4, I would not give Lasix. Now, sometimes the nephrologist or urologist will ask us, they'll say, we're going to do surgery on this right away, but we want to know, the question is, do we have any function at all? And in those cases, we use Lasix really kind of no matter how much obstruction there is, because their question is, should we even try to save this kidney or do we just need to replace it? The next question, how to diagnose PUJ stenosis without ionization investigation? I'm not sure I fully understand that question. Posterior urethral stenosis might be what they're asking about without ionization investigation. I'm gonna move on because that one's a little bit confusing to me. As a side, how often do you screen for cancer in hemihypertrophy patients? I would say always. Anytime that you see signs of hemihypertrophy or arteriovenous malformations that can indicate hemihypertrophy or renal asymmetry or nephroblastoma, or of course Wilms tumor, we screen all of those patients. So the diagnosis can be made prenatally, but it's often made at birth, when there's sort of physical exam findings of hemihypertrophy. And then we watch. If we find nephroblastomatosis, we watch recurrently throughout childhood for any transformation into Wilms tumor. Last question on this Q&A section: is accessory cavitating uterine malformation congenital? Accessory cavitating uterine malformation. The word cavitating to me implies that there wasn't a space and then there was the creation of a space because of some inflammatory or interrupting process. So I would only use the word cavitary or cavitating in my reports to indicate that I thought this was post-development, post-embryologic. If I'm going to call something congenital, it was always there from the very beginning. In fact, it was a failure of fusion. So in uterine malformations, it's not that something happened to the uterus, it's that something didn't happen to the uterus. Tissue never disappeared that should have disappeared. So I would use those terms separately: congenital for the Mullerian duct anomalies, cavitating to indicate a later process. I'm just going to check the chat real briefly in the event that there's some questions there. And it looks like there's one question: can we use Doppler to screen children with reflux by studying ureteric jet? Yeah, that's a similar question to our earlier, and I think I've seen it, so I know it's possible. I don't know what the data is on how sensitive and specific it is, but I do know that there is good data that if you want to use ultrasound, the better way, the more sensitive and more specific way, is to familiarize yourself with contrast enhanced ultrasound. There's a lot of agents on the market now. There's been a lot of research in the last 20 years, and it's a much more proven and well-developed modality. Studies on ureteric jet for vesicular-ureteral reflux, I don't know any off the top of my head. So you would have to search the literature, but I have not seen any large studies on that. Okay, thanks everyone for your attention.
Thank you so much for sharing that lecture with us today, Dr. Brown. And thanks to all for your participation in our noon conference. A reminder that you can access the recording of today's conference and all our other previous noon conferences by creating a free MRI Online account. If you'd like to access our Mastery Series courses, case series, and much more educational content with unlimited CME, you can sign up for a free 7-day trial of our premium membership. Be sure to join us next week on Thursday, September 29th at 12 p.m. Eastern Time for a lecture with Dr. Mahan Mathur on liver transplant imaging. You can register for that lecture at mrionline.com and follow us on social media at the MRI Online for updates and reminders on upcoming noon conferences. Thanks again and have a great day.
Bye-bye. Thank you.